Hello, and welcome to 5-Minute Nephrology. My name is Dr. Nephron because anything saltier would be bad for your health. Today we are going to learn about nephrotic syndrome, more specifically minimal change disease, all in about 5 minutes, but don't hold me to it. We'll also touch on steroid-resistant nephrotic syndrome / FSGS to round out the entire field. Definition of nephrotic syndrome. Well, nephrotic syndrome, remember, is a description. It is not a diagnosis. It features proteinuria, so urine protein-creatinine ratio greater than 2 milligrams per milligram, hypoalbuminemia, less than 3, edema, and hyperlipidemia. What is the epidemiology? The incidence is around 1 to 17 per 100,000 children per year, and so you will likely see at least one of these in your practice. Peak age is around 2 to 7 years. It's a male predominance. Minimal change is the most common disease, which we'll talk about shortly. And of those with minimal change disease, around 80 to 90% are steroid sensitive, and therefore there is no need for a biopsy. The pathogenesis is podocyte injury leading to proteinuria, foot process effacement. Minimal change disease is immune-mediated, which is those discovered a number of years ago, where FSGS also features structural injury leading to sclerosis, and thus the name focal segmental glomerulosclerosis. And here you can see the pathogenesis. On the left you have the normal GBM, intact foot processes, slit diaphragm in between, and the GBM all looking healthy. On the right you have minimal change disease with effaced podocytes. The podocytes are flattened, you lose the slit diaphragm, and thus you lose some of that barrier integrity and allows proteinuria to go through. When we think of the pathogenesis of nephrotic syndrome, again, we have minimal change disease and FSGS, or steroid-resistant nephrotic syndrome. Minimal change disease is immune-mediated, and that's why some of our medications, like steroids and rituximab, work. Whereas FSGS can be primary, which is idiopathic, secondary to, say, adaptive FSGS, to, let's say, sickle cell anemia or obesity, as well as genetic FSGS, where there's genetic mutation leading to the FSGS. Since we discussed genetics, when we think of genetic testing, when would we do it? We would consider it in infants or those with steroid-resistant nephrotic syndrome, depending on the age and in conjunction with the biopsy. When we think of the genetic mutations involved, we think of NPHS1, NPHS2, WD1, and LAMB-beta2, particularly in the congenital nephrotic syndrome in those infants. And unfortunately, with genetic nephrotic syndrome, they have a poor steroid response, as well as to other immunosuppression. As touched on the last slide, when we're looking at the differential, it's very important to look at by age. So in those who are the youngest, congenital nephrotic syndrome, less than 3 months, we think of genetic nephrotic syndrome, like we talked about, NPHS1, NPHS2, etc. Those are severe, tend to be steroid resistant, and there's not much we can do. Infantile, those 3 to 12 months old, we still think of genetic, but we also have to think of other things, other causes, such as infectious causes, ear torch infections, as well as minimal change disease. So we would consider genetics early. Early childhood period, 1 to 10, that's your main age for minimal change disease. So again, 80 to 90% of these children will have minimal change disease, and 80 to 90% of those will be steroid responsive. So as I mentioned earlier, you do not need to get a biopsy typically. Once you're getting into the adolescent period, however, FSGS, lupus nephritis, membranous nephropathy, those tend to be a bit more common, while minimal change disease is still the most common. However, its relative percentage starts to decrease, and FSGS, lupus, and membranous nephropathy start to increase, and so biopsy is typically needed. Once you get into the adult world, secondary causes are more common. What are some of the clinical features? Well, edema, periorbital in the morning, and then as the day moves along, goes to dependent areas like the legs, then back to the face in the morning. Tend to have weight gain, ascites, pleural effusion if the weight gain and edema is significant enough. Some of the complications of nephrotic syndrome: infection, thrombosis, renal vein thrombosis, which we'll talk about a little bit later, as well as loss of binding proteins such as vitamin D binding protein and thyroid. Lab findings, we mentioned them in the outset. Urine proteinuria with urine protein creatinine ratio greater than 2 milligram per milligram. Can have microscopic hematuria, but not as common in minimal change disease, more so a feature of FSGS at times. In the serum, you have low albumin, which we talked about earlier, as well as elevated lipids. Can have dysnatremia depending on the fluid status. Otherwise, The rest of the labs are oftentimes normal, and the CBC may be concentrated due to intravascular depletion. When we think of our differential, again, we kind of touched about this earlier. Minimal change disease, here heart is that 1 to 10 year age, most commonly 2 to 7 year. Abrupt, there's edema, otherwise they are well. Normal complement, B and T cell mediated podocyte injury like we discussed. FSGS typically occurs in older children. Hypertension, hematuria can happen, progressive CKD as well, since oftentimes they tend to be resistant to steroids and possibly also resistant to other immunosuppression. And again, over time, podocyte loss with sclerosis, and that could be, in addition to primary FSGS, can also be genetic or adaptive, like we mentioned, obesity, sickle cell disease examples. Membranous nephropathy also occurs in adolescents and adults. Normal complement. In adults, they have this antibody to PLA2R, less common in children, and it features immune complex deposition. This is a much less common cause of nephrotic syndrome. Lupus podocytopathy occurs in adolescents. They may have other signs and symptoms, systemic symptoms. Complement is typically low, and then you have features of immune complex disease. Congenital nephrotic syndrome, we talked about earlier, in those less than 3 months. Severe edema at birth or even up to around 3 months of age. Severe hypoalbuminemia, and again, typically genetic, and steroids do not work. Secondary nephrotic syndrome, which could be at any age, depends on the cause, and we talked about some of those causes: infection, drugs, systemic disease. Here we have a case example, and this is kind of classic, especially for the boards. 4-year-old who presented to the primary care doctor with eyelid swelling. He was prescribed an antihistamine, but the swelling did not resolve. Came back to the PMD a couple of days later, who dipped his urine, which demonstrated 4+ protein, and he was referred to the emergency room. His vital signs are stable and within normal limits. Serum labs with an albumin of 1.8, otherwise within normal limits. Lipids are elevated, including triglycerides as well. Urinalysis shows that his specific gravity is 1030, so a bit on the dry side, or lots of stuff in it, such as 4+ protein, 1+ blood, positive leukosterase, which is just a sign of systemic inflammation. Urine protein creatinine ratio is 4.5 milligram per milligram, so significant, and he has a few WBCs in his urine. So now that we talked about some of the features of nephrotic syndrome, as well as minimal change in FSGS, we'll come to some of those subclassifications of minimal change disease. So steroid-sensitive nephrotic syndrome, where typically you have remission on high-dose steroids after 4 to 6 weeks. Steroid-dependent nephrotic syndrome is a relapse while on a taper of steroids. Frequent relapsing is at least 2 relapses in 6 months or 4 in 12 months. In steroid-resistant nephrotic syndrome, there's no remission, or they were once steroid responsive but are no longer responsive, in which case you'll oftentimes get a biopsy. Treatment algorithm. So oftentimes you'll see them admitted for the first presentation of nephrotic syndrome. Some of that is due to just education, and some of them is due to their pretty severe presentation, in which case they'll be admitted for IV steroids because the edema is not just in their skin, but is also in their gut and decreases absorption. As part of this, the steroids is definitely the treatment, but we also emphasize a fluid restriction, low salt diet to prevent some of that edema, plus or minus Lasix if they need it, and some providers give albumin and Lasix depending on how severe the edema is, as well as the hyponatremia. Steroids is the mainstay of therapy, like we discussed. High dose, 2 milligram per milligram for about 4 to 6 weeks. And then if they are steroid sensitive, like we mentioned earlier, you'll taper every other day. If there's a relapse during the taper, that's called steroid-dependent nephrotic syndrome. Frequently relapsing or steroid-dependent nephrotic syndrome, you'll ideally try a steroid-sparing agent, such as some other immunosuppression, like anti-CD20, like rituximab, MMF, or tacrolimus. If there's steroid-resistant nephrotic syndrome, as we discussed earlier, biopsy plus or minus genetics. What are some of the complications on the follow-up? Well, we mentioned steroid-sensitive nephrotic syndrome will respond to steroids. What a lot of residents are not aware of is that 80+% of them will have at least one relapse, and 50% of those will have even more than one relapse, putting them into the steroid-dependent or frequently relapsing category. Typically, minimal change disease resolves in adolescence, but 10 to 20% persists into adulthood. Some of the complications, which we'll look on the next slide: infections and thrombosis, and of course, if they're on frequent courses of steroids, we have to monitor for growth as well as steroid toxicity. Some of the complications, especially the board relevant ones and the kind of the important ones that you'll see, I bolded. But thrombosis, with the protein C, protein S loss in the urine, as well as antithrombin 3, leading to renal vein thrombosis. Infection due to immunoglobulin loss, such as spontaneous bacterial peritonitis with strep pneumo, as well as cellulitis, vitamin D binding protein, decreased thyroid binding globulin protein, and the edema can lead to significant fluid overload. What are the key points? Minimal change disease, nephrotic syndrome, is a podocyte disease. Minimal change is the most common cause of nephrotic syndrome, but again, pay attention to the age. Classification drives management, as we discussed. Most minimal change disease falling in that 1 to 10 age range, 80 to 90% of them will respond to steroids, but again, many of them will relapse, have at least one relapse, and many of those will have multiple relapses. And if they do not respond to steroids, then you have to start thinking of genetics, biopsy, trying other immunosuppression, but that may not work. Complications that you'll most commonly see on the boards, as well as in your career, is infection and thrombosis, as well as the other things such as fluid overload. Remember that fluid restriction is very important, as well as Lasix if necessary. And on this last slide, we have some of the references that are applicable if you'd like a deeper dive on the topic, because who wouldn't? That's your 5-minute, kind of, nephrology on nephrotic syndrome with Dr. Nephron. Until next time, you're in good hands with renalforresidents.com.